Jesper Thulesen is my name. I'm an oculoplastic surgeon based in Copenhagen, Denmark, but also work as an aesthetic physician in 2 aesthetic clinics, also based in Denmark. Disclosures. So aging is a privilege denied to many. So don't forget that the clients, the patients that we get to our clinic are kind of privileged patients. It's a physiologic process of the body in response to the passage of time. The objective of this webinar will be to introduce you to the predictability of facial aging, because this is an important complex process that can be used very usefully in your way to target the treatment of the patient. And it's also a useful tool to structure treatment plans for the individual. So in other words, the predictability, you probably all know these processes in aging, but let's briefly go through the most significant changes, because remember, everything is more or less pre-programmed, and it plays an important role for our aesthetic treatment. So if we kind of divide the processes into 3 main components and start with the structural changes, we start to lose bone as we age. The bone is the frame upon which the fat, muscle, and skin is suspended. Some bony areas start to shrink faster than others. In the face, primarily the frontal eminence, maxillar and mandibular bones undergo resorption when the years add on, and the nasal and orbital apertures also become wider, which all lead to a reduced bone support for the overlying tissues. To deflect decipher her triangle of youth. This is the patient that I will use for the model of our webinar. And of course, at the pre-examination consultation, one should know the quality of skin, the elasticity, amount and location of subcutaneous tissue, the depth of the nasal label fold, degree of jawing, deflation, overall deflation, skeletal support, malar convexity, and submalar concavity. But the inverted triangle shape of the youthful face become more as a square as we age, with our cheeks becoming our jaws and our lower facial skins living under our jaw, Interestingly, the posterior part of the mid cheek and mid and lower face differs from the anterior part, because due to the tight ligamentous attachment, the posterior smash is more fixed and prevents, to some extent, ptosis of the tissues in that area. So we don't see that much descent in the posterior part of the cheek due to the fixed smash. In the anterior part of the cheek, we have the so-called mobile smash, which with time, with age, will develop more laxity and then allow the descent of the deeper structures. This is why we often see patients with ptosis of the tissue in the lower face, predominantly localized in the area between the fixed smash and the mobile smash.